Hi, I'm Dr. Sam King, medico-legal consultant with Medical Protection. Welcome back to the part 2 of our Medical Council podcast, and I'm joined again today by Tim and Adam.
Hi, Sam.
Thanks, Sam.
Welcome. Let's move on now. I want to talk about another fictitious case about Dr. K, who relocated to work as a doctor in a small DHB. Dr. K was keen to start a private specialist practice alongside his work at the DHB. And for the first 3 years, everything went well at the DHB, got on well with his colleagues. And at that point, he had a major surgical complication in a patient who sadly died. There was an internal investigation into the case, and Dr. K's care was criticised. He took learnings from this, and life carried on. There were a few more issues along the way, but nothing major. He did notice, however, that tension was developing between himself and the head of department where he worked at the DHB. And Dr. K kept his head down and continued working. He began to make plans to enter into private practice. Being a relatively small centre that he was living in, there was a group practice where many of his colleagues worked in private, so he was hoping to join them. Unfortunately, as tensions within the department rose with his head of department, his colleagues advised him that they no longer had an opening for him in private. So he decided to strike out on his own and became credentialed with the local private hospital. He began his private work and was gaining some momentum in his private practice, and at that point he received a notification from the Medical Council. 2 of his hospital colleagues had raised concerns about his competence, citing the patient who died several years earlier and other patients who had experienced complications. And this was the first Dr. K knew of these significant concerns when he received the notification from Council. And he strongly felt that the motivation for the complaint was the personality clash he had with the head of department, but also the rivalry for his private patients. So Dr. K responded with our assistance to the NTT, who referred the matter to full council. Tim, just in the minimal facts that I've given you in this fictitious case, what do you think would be the likely path that council will take?
Look, I find these cases really, really difficult because in your heart, you're hoping that council will pick up the fact that the motivation for the referral was this interpersonal stuff, and that if you look at anybody's case histories enough, you'll find some evidence of actions which might be questioned. And so all of us, if we had our notes all examined carefully, could end up in front of the council if someone didn't like us and had been going through our cases. So it's a kind of an awful situation to be in. From the council's perspective, though, they've still got an obligation to ensure the competency of all of the doctors that they're registering. And so despite my internal frustrations, I can understand that the council feels obliged to actually look more into this. They can't just accept the letter from the doctor and say, look, that's absolutely fine, because I think, if I was on the council side, I'd say, well, they're not doing their job properly by doing that. So they've got to take some actions to try and reassure themselves that this doctor is performing competently and that, yep, he may have had some things that happened, but there is no doctor who has ever practiced who has not had problems that have occurred. So they've got a couple of options, and the determination as to which they'll use depends on how serious they think any possible deviance from good practice might be. If it's not a big matter, that just a couple of minor things, then they might undertake what's called a preliminary competence inquiry, which personally I don't think they use frequently enough, because it's a much simpler process than the other option, which is a performance assessment committee. So the preliminary competency inquiry, PCI, involves a colleague from the same branch of medicine having an interview with that doctor, which might last for 3 or 4 hours. So it's quite a long and detailed interview. They may look at other cases to get an idea, look at some notes of other patients to get an idea of what the general kind of standard is. They'll want to be reassured that the doctor's keeping up to date with their CME, that they're not working in isolation, all of those things which combined together will help give reassurance that actually, no, this doctor is fine. But in my experience of the few where that's been used, yes, the original complaint has been pretty minor, but the result has been good for most of the ones that I've been involved with the PCI. The outcome has been, yeah, look, this doctor's good and we don't need to go further. More likely, they're going to go to a performance assessment committee, which is a whole other order of magnitude of assessment.
Interestingly, likewise, for any of the members that I've had cases with, when they've gone through a PCI, they've all passed. Which is interesting to me. That might indicate the fact that they choose those particular members to have a PCI very carefully, and that they do a good job with that. The whole PAC, or the Performance Assessment Committee process, I often say to members it's an educative process, and council, it's not disciplinary at all. It is educative, and council are really interested in remediation if that's necessary. The difficulty, of course, for our members is it feels disciplinary, because any time we're before our regulator, it's a big deal. And it is very stressful, but it isn't a disciplinary issue. And as Tim says, I'm sure that on any given day, if you looked at any of our clinical care, you'd find holes in it. So how much does council take into account the personality clash and business rivalry?
I share Tim's view that it will only be in very rare and clear cases that the council will accept that the notification is so clearly motivated by some personal animus that it doesn't really need to be taken seriously. Even in cases where there's obviously bad blood, nonetheless, if there's a notification that comes in to say, I'm concerned about Dr. So-and-so's competence, the council will feel the need to respond to that in some way. And over time, sort of increasingly so. I think 10 years ago, might have been more confident about being able to persuade them that this was, two partners who had fallen out. These days, I think, as soon as there's a competence concern raised, if it's got any meat behind it at all, a specific case with notes in the practice management system, then the council will want to have a look at it. And as both you and Tim have said, it would be nice to have PCIs used more often, but it is more common that when faced with that kind of situation, a matter coming to full council, the council will treat it as on its competence track rather than its conduct track, send it to a performance assessment committee, and then the committee will do its job. And there's a very sort of well-established protocol almost for what performance assessment committees do. They do learn about the reason why the cases come to them, which sometimes can feel a little unfair because the process is supposed to be forward-looking. Are you competent now? This is not an inquiry into the Sentinel event. It's an investigation into the doctor's current practice and whether or not it meets the required standard. But it's a process that can take a number of months to organise and then several days to undergo, where this committee of 3 people will review notes, have sent out surveys in advance to colleagues to get feedback on you, will have an extended interview with you, watch you do consultations or procedures if you're not a GP, and then ask you questions afterwards as a bit of an OSCE of why did you write that there and what other medicines could you have used to address that. So it's quite an ordeal, and the end product of that is that the committee will write a report about the doctor's performance and give them a grade essentially of a 1, 2 or a 3. A 1 is that you're fine. A 2 is that you're not unsafe, but there are some things you could polish up on. and a 3 being Houston, we have a problem. So it's actually difficult to get a 1 because anybody undergoing that degree of scrutiny, there'll always be occasions where you're rushing to get home perhaps and didn't write the most comprehensive notes. So members who go through and get a 2 shouldn't feel ashamed of themselves. Those reports then get referred back to council to decide what to do. So it's not the performance assessment committee that then determines your fate. They simply assess you, and then the council responds to that assessment.
And in the case of a 2, what they'll usually come up with is some suggestions of areas that you need to improve, and they'll formulate a plan for that. So, for example, your notes are regarded as being not sufficiently detailed, then they'll want to see an audit of your notes, and they'll want to do a notes review in 6 months' time or whatever. They may recommend educational activities that you need to do. There's a whole variety of things that, but you're right, they're all intended to improve that individual doctor's practice and therefore improve the safety of the patients that he or she is seeing.
Yes, that's right. So there'll be an educational program devised that is targeted towards any areas of concern identified by the Performance Assessment Committee's report. Sometimes in more severe cases, there might also be at that stage a request for a voluntary undertaking or some sort of engagement with a supervisor where perhaps a subset of notes is reviewed each month, or prescribing of benzodiazepines is subject to review, those sorts of measures. But it is a process that can be worked through with time, and if a practitioner successfully addresses the program that they've been delivered by the council, then at the end of that, that's the end of the matter and we all move on.
And I think the thing for our listeners to understand is that council do want us to be working. They want doctors to be back in practice and practising safely. And so if you set that as the end goal, and knowing that council aren't there to punish you, but just in their way to assist you to get to that point, then I think it probably helps to deal with the stress of it, because it is a very stressful process.
It's actually exceedingly rare for a doctor to be struck off for lack of competence. And usually what happens is that there's some fairly serious discussions occur. And I do recall one case where an elderly GP had his pack, and I was rung by the council that same evening to say, we need to make sure this doctor never sees another patient again. Can you help to ensure that...
Was that me when I had my pack?
Let me just remember King that day. Yeah. So sometimes things have to happen very quickly, but that doctor wasn't struck off. He just immediately handed in his APC and recognised that the time had come for him to no longer practice.
And I think that raises another point, that most of us, when our competence is questioned, most of us do want to hang it up, hang up the stethoscope. And that's just a very natural and common reaction. So I just encourage you, if you receive a complaint or someone, raises questions about your competence, please resist that first impulse to go into retail. Retail's doing really badly now anyway, and it doesn't pay really well. So, but that's certainly the first impulse that we have. If we look now at, I know that most doctors are reluctant to notify council about concerns they might have about a colleague. Tim, when you have members call you about that, they've got concerns about one of the colleagues that they're working with and ask what should they do, what would you explain to them, or what advice would you give them?
Yeah, an awful lot depends on the relationship that they have with that particular colleague. So if it's someone that they actually genuinely get on well with and feel that they could sit down with them and have a discussion and point out to them the examples that they've seen where they believe that the actions that they've taken have not been particularly wise, then that's certainly the first part of the process. And if the doctor involved is receptive and says, yeah, look, I accept that I've been seeing too many patients or whatever, and they come up with a plan that looks as like it will help improve the situation, then I think that's a good starting point. But the doctor who's got the concerns would still want to be reassured that in 3 months' time or whatever, that things have improved. And it is actually really difficult. as a colleague, you can't really act in that, especially if you're closely associated with that doctor, as their judge and jury. So it's often better to have an outside person look at it. Now, we've had situations where sometimes the doctors have contacted the PHO and said, look, some concerns have been raised about this particular doctor. Is there someone who can come in and do a notes review and maybe sit on a few consultations and see if this is something we need to take it further and notify the medical council, or whether it was just chance and we really don't need to have any concerns. And so that's another good way of getting an independent person to come in who's got some standing within the medical community and who can then assist with that judgment as to whether to refer or not. The bottom line, I think, that doctors need to think about is if they found in 6 months, if they didn't do anything, despite their concerns about the competence of the doctor, and then in 6 months' time they find that this doctor's made a terrible mistake and a patient has really suffered harm as a result, how are they going to feel about that? And if your decision is actually, I'd feel really bad about that, then that's maybe enough of an impetus to say, okay, I need to take all the steps that are needed to ensure that they are okay, and ultimately that's referral to the medical council.
Mm-hmm. And I think you're right, Tim. It must be a really difficult judgment call to make. There are, though, some circumstances where a notification must be made, and that's if someone has been has resigned or is dismissed from their employment for reasons relating to competence. Then the employer who's just been left has an obligation to notify the medical council about that, and that's written into the Act. So there will be occasions where that discretion has been taken away and there's just an obligation to notify.
And if you're listening and you do have concerns about a colleague, medical council have a statement when you have concerns about a colleague, which you might want to have a look at. It is on their website. Let's move on. Lastly, we're going to talk about the Health Committee. And Tim, would you like to talk about the function of the Health Committee?
The Health Committee is there to look after the health of doctors. Well, not really to look after, but to monitor the health of doctors. So you're most likely to appear in front of the Health Committee if you've had some sort of illness which could potentially render you less safe in your interactions with patients. And the vast majority of people who end up in front of the Health Committee, it's because of psychological problems, and addiction is a big one. So alcohol, addiction to medication, and in those circumstances, there's often a conduct overlap as well, because if you're someone who's addicted to benzodiazepines and you've been self-prescribing those benzodiazepines, then you're almost certainly going to end up both with the Health Committee and also with a professional conduct committee to explain your actions. So the Health Committee, it's kind of quasi-autonomous within the council, but there is that ability for them to refer information through to the full council if they believe that conduct is an issue. If a notification is made to the Health Committee, then the committee will want to get information about your health, and that will be from you yourself. It'll be from your doctor, and they may also want to get independent assessments as well. And the bottom line is that they're wanting to make sure two things, the most important one being that your health is not going to have an impact on your patient's safety, but also that secondarily that your work is not going to have an impact on your own health. So they do balance up those two factors.
Adam, when should we consider whether we have to self-notify to the Health Committee, and what obligations do we have if we know that one of our colleagues is experiencing health issues?
So medical practitioners can be referred to the Health Committee by the Medical Council itself. So sometimes a notification will come in, or something will be discovered in the course of the council engaging with a practitioner that leads them to the view that this is someone whose case needs to be considered by the Health Committee. And as Tim said, it has a sort of function within the council that is I assume, designed to encourage people to engage with it. That it is neither competence nor conduct, and it is really there just to focus on fitness to practice, and has a slightly more therapeutic perspective because of that. There will be occasions, though, where a medical practitioner having insight into a health condition of some sort, and often addiction, will have to make a decision about whether the best course of action is, in fact, to go to the medical council and declare directly to the health committee that concern, which will immediately result in an engagement with the health committee. Now, a really appropriate case to seek advice on. A serious health concern, the answer is probably self-evident that yes, you should be engaged with a health committee if you've got a health concern that that puts into question your fitness to practice or your safety in all circumstances with patients. But there's a right way and a wrong way to engage with the health committee. So being assisted to first make that really big decision to go and reveal the problem that you have, I think is appropriate. But then to do that in an informed basis, to appreciate that if you are also going to disclose conduct issues, so I have a problem with addiction, but I have also been taking medicines from the safe, there's some thinking that needs to go into how to deal with that problem proactively, because there will, if that's disclosed to the health committee, they will then refer the prescribing issues on as a conduct issue to the council. And it's also a good idea to go to the health committee with a plan if you can. You're probably going to have a on balance better outcome if you can front up and say, I have received insight. I am now insightful, and I know now that I need to declare myself to the health committee. I am an alcoholic, but I am currently engaged with a psychologist, and I am attending Alcoholics Anonymous on these days, and I'm very happy to use a breathalyzer device on the morning before my clinical sessions start. Come with a plan. Not only will it give you, having talked that through with MPS or a lawyer, a good idea of what to expect anyway, so it's not a surprise, but it puts you more in the driver's seat in terms of what's actually going to flow on from that notification. And Sam, you also asked about what obligations doctors have to notify health concerns into the medical council. And the answer to that is in the Act, and there's also a good statement that's been published by the Medical Council about that, which is called What to Do When You Have Concerns About Another Doctor. And the answer is that under the Act, doctors must inform the council if they believe that a colleague's mental or physical health may be impacting their practice. So if you do become aware of a health concern and you think there's a risk of harm there, then there is an obligation to report. But it's not a bad idea to relieve yourself of the burden of that judgment call, or at least, a problem shared is a problem halved. That sort of call is one that MPSs and the MLCs are really well equipped to deal with and discuss with you and let you know that, yes, you are doing the right thing, and then how to go about that.
And one of the particular challenges there is that if you as a treating clinician have a doctor as a patient who then declares that they've got an addiction problem or an alcohol problem or whatever, you then have these conflicting responsibilities to your patient as an individual, but also to the council in terms of reporting under the Act. And one of the first things to do is to buy time, so that if you can convince your patient, look, you need to stop work immediately, take 2 weeks off, and then we can start going through the process of what we need to do. Because time gives you that opportunity to do the kind of things that you were talking about, Adam. Start getting a treatment plan organised, getting off to Alcoholics Anonymous, etc. One of the things that we think is that it's probably going to be better if the individual doctor notifies themselves as opposed to being notified by someone else, because that will give an indication too to the health committee that they're acknowledging that there's a problem and they're starting to take responsibility for it. The dilemma for the treating doctor is, he has this patient who says, yeah, sure, I'll report myself to the medical council, and then there's a big black hole because, has he reported or not? And so one of the things that we sometimes suggest in that scenario is you say to your patient, yep, that's great, look, that's absolutely the right thing to do. Today's Wednesday. I'm going to give the council a ring on Thursday of next week just to confirm that that's all happened, to make sure that things are going ahead. So you're giving that person the opportunity to self-report, but you're also tying up that loose end to make sure it's happened.
Yeah.
Oh, that's great. Thanks, Tim and Adam. In my experience, the health case managers on the health team are actually very good to deal with, and I find them very helpful. And the committee, the health committee, really have an aim to get doctors working again, and they will work towards that. They just obviously want you to work safely. And so if you do need to notify, or you are notified to the health committee, please don't be anxious about it. We can certainly help you through that process to make sure that you do get back to work effectively. So we've talked in this podcast and the previous podcast about the medical council process, and it can be very stressful. But I think if you contact your indemnifier, you'll find that we can walk with you through every step of the way, and it certainly helps to demystify it, and it'll help you get through the process and out the other side. Thank you, Tim, and thank you, Adam, for your time. And thank you for listening to this podcast. I hope it's been helpful, and we look forward to catching up with you on our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.